Thank you for attending to this very special edition of the annual meeting of the JPS Society. Here I will present a preliminary study that is part of our largest research project conducted as part of my PhD from the Complutense University of Madrid and the two most important pediatrical and oncological hospitals from Spain located in Madrid. The main objective is to enhance knowledge of the cognitive aspects of the experience of cancer during childhood and pre-adolescence from the perspective of the children, and to find out if there are differences according to the developmental age of the child or the experience of the disease itself by comparing the results between a sample of healthy and ill children. The incidence of cancer during childhood has grown in the past decade across the world, and nowadays it is the first cause of death by disease among children in Western countries. Although most of the oncological children survive cancer, around 85% of the cases diagnosed, their illness process entails long treatments and painful procedures with high levels of stress and psychological discomfort. Apart from the impact of the illness that has on the organization of the family life and on school adjustment, one important source of stress for sick children is the uncertainty about their conditions, particularly when they lack any understanding of the illness and people around them do not talk about it. How adults used to treat the severity of ill children in recent past is well illustrated by Berison in They Never Want to Tell You. However, omitting information about what is really happening to the children does not protect them from anxiety and distress. On the contrary, maintaining the children in a supposed condition of ignorance can lead them to elaborate or confirm false ideas about what caused the disease and what extent some of their past behavior triggered it. Although false ideas about the causes of cancer and non-realistic beliefs about the process of healing are also present among adults, this is indeed more likely to occur among young children, whose intuitive ideas about health and illness are fuzzy and often biased towards behavior and psychological explanations, intentions, will, desires of the illness process. Only by the age of 9-10 do children begin to incorporate a little more consistent biological view of health and illness, although obviously far from the scientific view. Research about conceptions of illness in healthy children of different ages is fairly extensive. However, much fewer studies have been conducted with children suffering chronic or life-threatening diseases, as diabetes, asthma, or cancer. Vivas and Walls offer an explanation of this fact, saying that until very recently, the therapeutic interventions designed to help the sick children were directed only to the affected level, toward modifying the feelings of fear, anxiety, or depression. Nevertheless, as they explain, it came obvious that the feelings of the sick child or adult were related to beliefs or concepts about illness, that is, to the way that the patient understood the illness at a cognitive level. Thus, clinical researchers are becoming more concerned with the cognitive side of the illness experience. Still, only a few studies have assessed the comprehension of cancer in oncological patients and whether their concepts about the disease differ from the healthy children's concepts. Results from this line of research are quite divergent. Some find that ill children develop more elaborated concepts regarding, for example, the causes of cancer as compared to healthy children. Others find the opposite relation between experience of illness and conceptual comprehension. Finally, other studies find that the developmental age, but not the experience of illness, is the best predictor of children's comprehension of the process and causes of cancer. But it is important to emphasize that providing adequate explanations to oncological children has several consequences, such as decrease the level of anxiety, improve the compliance with the treatment applied, and facilitate communication between the family and the child. These are some of the questions we deal with our general research. Do children identify cancer as a possible illness answer? How do children comprehend their illness? Do they consider cancer as a severe or a fatal illness? And in general, are there developmental differences? Are there differences regarding their personal experience depending on if they suffer from cancer or if they are healthy children? Here we present some of the findings from a larger research project about the cognitive, emotional, and social experiences of children and preadolescents with cancer. We explored the influence of two variables on children's comprehension of cancer: experience with the disease, with 52 cancer patients and 52 healthy children, and age, with children between 6 and 14 years old. For addressing these questions, with the main objective of using testimonies of children, we ran a research study which is based on semi-structured interviews. All the interviews were audio recorded for the subsequent transcription and analysis. The 52 oncological participants were recruited from two hospitals in Madrid, La Paz and Niño Jesús, and the 52 healthy children were recruited from two public hospital schools also in Madrid. We performed the interviews in a quiet room, in the hospital or the school. The analyses were conducted in two steps. First, we used descriptive categories based on a previous study by UNESCO in 2009 for each of the different topics addressed during the interviews: identification of cancer, perceived severity, causal attribution of the illness, and prognosis. Subsequently, we performed a qualitative analysis of the interviews to identify general levels of understanding. In this case, and in line with the Piagetian conceptualization of stages, the analysis took into account the complete interview transcript to establish the internal consistency of the concepts, particularly those related with causal attribution. Let's go deeper into the assessment tool. A semi-structured interview was created based on a long interview developed by Dominguez Ferry in 2009. A pilot study allowed testing and adapting the questions, particularly with the younger children. In order to contextualize the interview within a significant context and considering that under a stressful situation, as it is suffering cancer or talking about cancer, children could become nervous if we asked them directly, the participants were first told a brief story illustrated by different images of children treated in a hospital. All participants were individually interviewed about several aspects related to the disease, as identification of the illness, the causes, symptoms, and so on. Here I present some of the most interesting findings related with the three targets of this study. First, the identification of the illness, second, the perceived severity and perceived prognosis, and finally, the causal attribution of the illness by children. The identification of the illness differs depending on whether the groups are divided by age or by experience with the illness. First, older children identify the illness more readily than younger children, and they report cancer as the most common answer, while youngest children report other illnesses as responses. We found significant differences between the two age groups. Second, divided by experience groups, we found no significant differences. Thus, age is the best predictor for cancer identification and health status, and experience does not imply greater disease identification. Concerning the perceived severity of cancer, we found very significant results. By health condition, it is observed that oncological children referred to cancer as a moderate disease, and very few referred to it as a severe or minor. However, healthy children to understand cancer as a much more severe disease. We found significant differences according to health condition. In contrast, divided by age groups, there are also some significant differences, with older children understanding the disease as more severe than younger children. Along the same lines, As the previous results, we observed that oncological children hardly ever refer to cancer as a terminal illness, while healthy children understand the disease as terminal or curable. Therefore, health condition is the major predictor for perceived prognosis of cancer. Concerning the causal attribution of the disease, there is a higher prevalence of virus, random causes, and contagion responses. When we look at this data divided by age and healthy condition, we find that the following differences. When considering health condition, there is only one category with significant differences. However, based on age, 6 categories have significant differences. Older children have more elaborated answers including genetics, contaminations, and also random causes. Therefore, age is the variable that most strongly affects causal attribution of cancer. The main findings are divided into two different blocks. Firstly, regarding age, we found a correlation between the identification of the illness and also with the elaboration of responses regarding the causal attribution of the illness. Thus, according to the developmental stages of children, the older they are, the better they understand the illness and the better they identify cancer. Secondly, regarding health experience, we found that oncological children perceived the disease as less severe and more curable. So, they have more positive thoughts about cancer prognosis. This may be because they need a more positive cognitive thinking style. In addition, healthy children perceive the disease as very serious and even fatal illness. Therefore, the experience with the disease causes children who are suffering from cancer to need more positive thinking and more adaptive cognitions in order to cope with the difficulty of the situation. It is necessary to emphasize the need to provide children with adequate explanations adapted to their level of development or developmental age in order to reduce false beliefs and misconceptions. It is also important to emphasize that oncological children seem to acquire a more positive thinking about their diagnosis, so that they present a more positive thinking and this can bias their causal attribution and understanding of the situation. Finally, it is interesting to note that the experience does not imply an improvement in their understanding of the disease, so it is necessary to provide them with information about their disease to reduce their anxiety and negative emotions as well as to help them to cope with this difficult situation. Last but not least, I would like to offer some suggestions for future lines of research. First, there is a need for interventions involving communication with children concerning the disease, considering their developmental, individual, and emotional conditions, in order to provide them with information about the diagnosis and treatment if they so wish. Secondly, more research is needed on the understanding of the illness in oncological children in order to be able to carry out such communication interventions based on developmental theory. Thank you very much.